Hello dear students. So today we are going to continue our treatment portion, that is treatment of congestive heart failure, that is the drugs used in the congestive heart failure. Okay, as I previously told, the class of treatment for the congestive heart failure is like this, that we are giving the preload reducers, afterload reducers. Okay, so in this what was the treatment you gave? It is ACE inhibitors, ARBs, angiotensin receptor blockers, aldosterone antagonists. You gave diuretics. Number 5 you gave neprilysin inhibitor, and there I forgot to tell you regarding the vasodilators. Among the vasodilators, there is one hydralazine, another is isosorbide dinitrate. There are many others, but let me tell you here these two. You know, these drugs are safe in pregnancy. Actually, when you are going to start the treatment for the congestive heart failure, you first start with the ACE inhibitors, then ARBs. Okay, when the patient is tolerable to the ACE, then you go to the switch to the ARBs. And if the patient is again tolerable to the ARBs, then you start with these vasodilators. You know what vasodilators are going to do? This is the arterial side. Okay, this is your arterial side, and let me quickly tell you, this is your venous side. Okay, this is arterial smooth muscle. Say for this is arterial smooth muscle, and this is the venous smooth muscle, venous side smooth muscle. Okay, you know what hydralazine is going to do? Hydralazine is going to act on the smooth muscle from the arterial side and going to increase the nitric oxide synthesis. When nitric oxide synthesis, what is going to happen inside the cell? It is going to rather stimulate cyclic GMP, guanyl cyclase. It is going to activate the guanyl cyclase. You know what guanyl cyclase will do? Guanyl cyclase converts GTP into cyclic GMP. When there is increase in the cyclic GMP, there is increase at phosphokinase G activity, for PKG activity. And this PKG, when there is increased activity of the PKG, it is going to inhibit the calcium transport inside the cell. When there is less calcium inside the cell, that means your cell is relaxed. So the same isosorbide, but it acts on the venous side of the smooth muscle with the same mechanism of action. Okay, now coming to the third part of our treatment is positive inotropic drugs. You know, inotropic drugs include, let me tell you, positive inotropic drugs. Positive inotropic drugs include, number 1, cardiac glycosides, and the drug is here, the most important, the digitalis. Okay, number 2, beta agonists, and the drugs are dopamine, dobutamine. Dobutamine is having exclusive action on the beta receptor, whereas it is having action on the dopamine receptor as well as the beta receptors. Number 3 is the phosphodiesterase inhibitors, and in this class you are going to know amrinone and milrinone. Let me take one by one. Okay. Now, let me take first the cardiac glycoside. You know the cardiac glycoside? Regarding the cardiac glycoside, it is derived from foxglove. Digital is derived from the foxglove, that is digitalis purpuri. Purpuri. You know the man behind who studied these cardiac glycoside is William Withering, and he treated the patient having this condition, dropsy. You know what is dropsy? It is similar to that of edema. Previously edema को बोला जाता था dropsy. No? Okay. Now, digitalis having two drugs in the market. It is digoxin and digitoxin. You know what is the difference between cardiac glycoside, phosphodiesterase inhibitors and beta agonists? You know, phosphodiesterase inhibitors and the beta agonists, those drugs are given parenterally. This is the only drug which is given orally. Okay. Let me tell you regarding their pharmacokinetics right now here only. You know the digoxin is having half-life short. This is having short like a half-life of 36 to 40 hours, around 1.5 days. Okay, whereas digitoxin is having a long half-life, around 160 hours. This counts around 5 days. Okay, so which is having a quick onset of action? This one. Quick onset of action, the action starts within how many minutes? 20 minutes. Here the action starts around 60 minutes. ठीक? Now this is mechanism of action onset. Onset of mechanism of action. This is your half-life. Now coming to the protein binding. You know, this is having less protein binding, around 60%, I think, 30% around protein binding, not 60, it is having around 30 to 40% of protein binding, but it is having more than 90% of protein binding. So this is having more toxic effect. Number fourth is excretion. Regarding excretion, you know, it is having a renal clearance, renal excretion, renal. But this is having biliary excretion, hepatobiliary excretion, bile, through bile, going to secrete through bile. That means this is more toxic. This is more toxic than digoxin. So the treatment, if you are having digoxin and digitoxin, which you are going to prefer? Digoxin, because of few side effect. And when you are going to switch to digitoxin, only when your patient is having renal insufficiency, because excretion of digoxin is renal. If a patient is having renal insufficiency, that means they are going to aggravate the condition here in this case. Okay. Also, one more thing, you know, when you are giving a patient to a digitalis, that patient is known as digitalization. Digitalization. And you know, in the pharmacokinetic portion, there must be one loading dose for it and a maintenance dose. Loading dose is the first dose which you are giving, the main dose which you are giving, and after that you have to maintain the plasma concentration. That means you have to maintain the steady state. Okay, it's okay. Now coming to, before I'll tell you the mechanism of action, you need to know, you know, your heart is under the influence of both sympathetic as well as parasympathetic. You know the parasympathetic branches, right vagus and the left vagus. Okay. Regarding the distribution of this adrenergic receptors and muscarinic receptors. Your adrenergic receptors are distributed throughout the heart. It is present here, it is present here, mostly beta 1 receptor, beta 1 left ventricle, right ventricle, having beta 1 receptor. Everywhere you are having beta receptor, but your muscarinic receptors are mainly on atrium only. Okay, that too on the SA node, M2 receptor, AV node, M2 receptors. Okay, why I am saying that means, can I say that when you are using catecholamines like epinephrine, norepinephrine, catecholamines are having global action on heart, means, okay, global action on heart. Whereas parasympathetic nervous system is having only atrium action. Okay, but keep one thing in mind: when there is catecholamine action and parasympathetic action, say for when there is a vagus action on the atrium, at the same time there is a branch of sympathetic nervous system, this vagus activity predominates. That means if at the same time vagus are stimulated and one sympathetic branch is also stimulated, the vagus action predominates. Okay, coming to the mechanism of action, you know digitalis is having two action. One is direct action. A good doctor knows that digitalis is having direct action, but a very good doctor knows that it is also having an indirect action. Direct action is because of loading of calcium, that is why it is known as calcium loaders. You know, there are three conditions where calciums are loaded inside they are known as calcium loaders. Calcium loaders include ischemic condition. In ischemic condition there is loading of calcium. In digitalis condition, when you digitalize the animal or patient digitalization, that also these are increased calcium level inside the cell, And there is one more, sympathetic activity. This also increases the calcium level inside the cell. These are known as calcium loaders. Okay. Now, the direct action is because of the calcium. That means, you know, when you digitalize the patient, they are going to load calcium in the atrium, load calcium everywhere, load calcium in the SA node, AV node, load calcium in the right ventricle, left ventricle, everywhere they are going to load the calcium. That means every cell of the heart is having more positive charge. When there is having more positive charge, then every portion of the heart is having more electropositivity. That means it is going, if you going to stimulate any cell that is having resting membrane potential near the threshold potential, that means your heart is going to conduct your heart, any portion of the heart will act as a pacemaker. You know, primary pacemaker of the heart is SA node. Generation of the impulses starts from the SA node. Why not AV node? Why not bundle of S water? Because SA node reaches the threshold potential very early, other than because of the other cells. So when you load the calcium, that means when you are loading the cells with the calcium, you are loading the cells with the cations. And when you are loading the cations, that means there may be chances of generation of the ectopic pacemakers anywhere inside the heart. These are ectopic pacemakers. When there is increase, that means first, when you increase the calcium, that means you are increasing the strength of contraction, force of contraction. That means your digitalis is having positive inotropic action. positive inotropic action. Inotropic action. When you are increasing the calcium, that means you are increasing the chances of generation of more ectopic pacemakers. That means that is known as positive bathymotropic action. You know, let me tell you here, keep it in mind. One is inotropy, another is chronotropy, there is dromotropy, there is bathymetropy, and there is clinotropy. You know what is ino? That is force. What is chrono? There is rate. What is dromo? Is conduction. What is bathmo? Increase in the ectopic pacemakers. And what is clino? Velocity. So that means any drug, any condition which increases the force of contraction is positive inotropic, which increases or decreases accordingly positive chronotropic, negative. Which increases the conduction, it is positive dromotropic and negative dromotropic. Which increases the pacemaker cells, that is known as bathymotropic, and which increases the velocity. You know, let me tell you what is this velocity. That means, say for example, this is your heartbeat. Okay, this is your systole and this is your diastole. Say for example, when you give a patient epinephrine, you know what is going to happen? There is increase in the systole and there is decrease in the increase in the systole. Your heart will do systole at a faster rate, at faster velocity, and even when they relax, it relax at a faster rate. Okay, that means strength is also increased. Look at the strength here. Look at the slope. Look at the slope. Okay, that means this is when the condition is, it's only, say for example, there is no change in the slope but only change in the velocity, and there is no change in the diastole. That is, this only increases the force of contraction, but this increases the velocity of the contraction. So epinephrine increases the velocity of the contraction. Okay, and this is known as clinotropy. Okay. Now, so that means digitalis is positive inotropic because they are, how they are positive inotropic, I will let you know in the action part. This is bathymotropic. Why? Because they are going to increase the this ectopic foci. Regarding the indirect action, you know what, and also it also increases the velocity. So it is positive clinotropy also. Okay, three things. Now regarding the indirect action, you know indirect action is because of why? So I told you that it is under the influence of vagus. You know, right vagus goes to the SA node, left vagus goes to the AV node. If right vagus goes to the SA node, so there is decrease in the conduction, there is decrease in the generation of the stool, like in the SA node. That is, it going to cause the sinus bradycardia. Okay, number one. That means it is going to decrease the, so that means indirect action, we can say it is having vagotonic action. And when it is going to increase the vagus influence, they are going to decrease the heart rate. When they are going to decrease the heart rate, that means your digitalis is negative chronotropic. Okay. At the same time, you know when stimulus started from the SA node reaches the AV node, that means then the conduction start from AV node to bundle of his then Purkinje fiber. At AV node, if vibratonic action is on the AV node, there is decrease in the conduction. When there is decrease in the conduction, that means your digitalis is negative dromotropic. Dromotropic action. Okay, so your digitalis is inotropic, bathymotropic, clinotropic positively, and through indirect action it is having negative chronotropic action and negative dromotropic action. So let me stop it here, because in next class I am going to tell you the mechanism of full mechanism of action of the cardiac glycosides. Till then, goodbye.